Hello everyone, welcome back to my channel. So in this video we'll be talking about malignant melanoma. So according to the definition, it is a malignant neoplasm of melanocytic origin that arises from a benign melanocytic lesions or de novo from the melanocytes within otherwise normal skin or mucosa. So malignant melanoma, it is a malignant neoplasm of melanocytic origins. So melanocytes are the cells which are responsible for pigmentation in the skin or body. So malignant melanoma, it arises either from a benign melanocytic lesions or from the melanocytes, the cells which are responsible for pigment production. So malignant melanoma, it is the third most skin cancer and it accounts for 3% of all the malignancies. So the most important etiological factors which cause malignant melanomas are environmental factor and the genetic factor. Coming to the environmental factor, the most important factor is sun exposure. So highest incidence rate is seen among the persons who are exposed to sunlight throughout the year. Okay, lower risk is seen among those persons who during their childhood used to reside in a low ultraviolet radiation environment, okay. So intermediate exposure to the higher intensity ultraviolet UV is more important in causing melanoma than the continual exposure. So sunlight plays a very important role for causing malignant melanoma. High intensity UV is one of the most important factor. Other factors like artificial UV sources can also cause malignant melanoma. Socio-economic factors also plays a very important role. People who are from the higher economic societies or who are having hobbies for the expensive outdoor habits are also prone for malignant melanoma. People with fair skin, having freckles, red hair have increased risks of melanoma. It is also seen among the person who have higher number of melanocytic nevi. Coming to the genetic factor, it is the familial melanoma. So higher risk is seen among those persons whose relative has a history of malignant melanoma. So the two important factors, one is environmental, another one is familial. In environmental factor, what we have seen, sunlight, that is high intensity UV plays a very important role, followed by artificial UV. And in genetic factor, what we have seen, familial melanoma, that is people whose close relatives had a history of malignant melanoma are having 2 to 8 times greater risks of having malignant melanoma. Now coming to the clinical features, it is seen mostly among the whites. In the adults, the average age is 55 years. Males are more frequently affected than the females. Skin, 80%. Orally we can see palate, maxillary alveolus and gingiva are the most frequently affected side. The other sides are mandibular gingiva, buccal mucosa, floor of the mouth and the tongue. So 4 clinico-pathological types of malignant melanoma has been described. These are superficial spreading melanoma, nodular melanoma, lentigo-maligna melanoma, acral lentiginous melanoma. So Clark and co-workers in the year 1975 have documented 2 growth patterns for malignant melanoma. 2 growth patterns. First, radial growth pattern. Second, vertical growth pattern. So coming to what is radial growth pattern. So it is the initial growth phase of the tumor where neoplastic cells are shed with normal maturing epithelial cells. So these neoplastic cells which penetrate the basement membrane are destroyed by host cell response. So what have we seen? Malignant melanoma can spread by 2 growth patterns. One is vertical and another one is radial. So radial means it is the initial growth phase of the tumor. Here, when the neoplastic cells are shed, means when they try to penetrate the basement membrane. The neoplastic cells, when they penetrate the basement membrane and they try to invade the connective tissue, these are destroyed by host cell response. So it predominates in the lentigo malignant melanoma, superficial spreading, and the acral lentiginous. So in this photograph, what we can see, radial growth pattern and the vertical growth pattern. So radial growth pattern, what we can see when the melanocytic cells, they are penetrating the basement membrane and coming to the connective tissue, these are destroyed by host cell response. Now coming to the vertical growth phase. So this phase begins when the neoplastic cells populates the underlying dermis. Takes place because of the increased virulence of the neoplastic cells, decreased host cell response, or both. So out of the three clinicopathologic types, the vertical growth phase में we can see the nodular melanoma. So nodular melanoma predominates in the vertical growth phase. Metastasis occurs when the melanoma enters the vertical growth phase. So in the radial growth phase, what we can see, the malignant cells, when they are penetrating the basement membrane and they are trying to invade the connective tissue, they are destroyed by the host cell response. Okay, so they spread in a radial growth pattern. Whereas in the vertical growth pattern, what we can see, vertical growth pattern we can see the neoplastic cells, they have penetrated the underlying connective tissue. So metastasis can occur in the vertical growth phase. And out of the four clinical types, in the vertical growth phase we see the nodular type. Okay. So now coming to the ABCDE rule for the diagnosis of malignant melanoma. So what do you understand by the ABCDE rule? So ABCD rule means A stands for asymmetry, in which one half does not match the other half. So A means asymmetry. So in the picture we can see symmetrical and the asymmetrical lesion. So asymmetry means half of the lesion does not match the other half. So in malignant melanoma we will see first asymmetry. Second we will see the border irregularity. We will see blurred, notched or the ragged ones. So borders are uneven, borders are irregular. So A stands for asymmetry, B stands for border irregularity, C stands for color irregularity. Here pigmentation is not uniform. It is brown to black, white, red, blue, all can appear in the melanoma. So color irregularity. Usually in the pigmented lesion, what we see? We see one color. But in malignant melanoma, what we see? Multiple colors can appear. So A, B, C, D में C stands for color irregularity. D means diameter. Here it is greater than 6 mm growth. Okay, greater than 6 mm. Okay, so D stands for diameter and E stands for elevation. We will see raised surface. Raised surface can also be a sign. So A stands for asymmetry, B stands for border irregularity, C stands for color irregularity, D stands for diameter, and E stands for elevation. So this is the ABCDE rule for the diagnosis of malignant melanoma. Now coming to the oral manifestations. So it is orally it is seen more among the males. Average age is 55 years. The most common site is palate, followed by maxillary gingiva and alveolar ridge. So in the picture we can see malignant melanoma which is occurring in the palate. In the down picture we can see it is occurring on the alveolar ridge. This is how malignant melanoma appears clinically. Now coming to the histopathologic feature. Atypical melanocytes are initially seen at the epithelial connective tissue junction. From here, they have the potential to proliferate throughout the epithelium laterally along the basal cell layer and downward into the connective tissue. So, what we have read, malignant melanoma can spread in two growth patterns. One, radial growth pattern, another one, vertical growth pattern. In the last slide we have seen in the picture, radial growth pattern and the vertical growth pattern. So atypical melanocytes, histologically what we will see, atypical melanocytes which are initially seen at the epithelium and the connective tissue junction. Okay, so from here they can spread in two directions. That is the two growth pattern. In the radial growth pattern, what we will see, they are spreading laterally along the basement membrane. Okay, whereas in the vertical growth pattern, what we will see, we have read in the clinical features, कि vertical growth pattern में what we will see, they have penetrated the basement membrane and they have invaded the connective tissue. So these are the two growth pattern. Okay, so atypical melanocytes are seen scattered singly among the basal cell layers or nest within the basal cell layer. Okay, so atypical melanocytes we will see they are present in a single or as a nest. Okay, so these are larger than the normal melanocytes and have a varying degree of nuclear pleomorphism and the hyperchromatism. So these atypical melanocytes, we will see them scattered singly in a single among the basal cell layer or as a nest. Okay, so these melanocytes, they are different from these atypical melanocytes are different from the normal melanocytes. They have nuclear pleomorphism and the hyperchromatism. So in the photomicrograph, what we can see, we can see yellow markings. We can see here what we can see, they are present as a nest and they are present along the basal cell layer. Okay, so in the radial growth pattern, what we will see, we will see these atypical melanocytes, they are spreading laterally along the basal membrane. When they are trying to invade the connective tissue, they are destroyed by the host cell response. But in the radial growth pattern, what we will see, that is in the nodular melanoma, they have in the vertical growth pattern, what we will see, in the vertical growth pattern we will see they have invaded the connective tissue and metastasis can be seen, which we can see in the nodular melanoma. So here we can see atypical melanocytes. So now coming to the superficial spreading melanoma. So larger melanoma cells infiltrate the surface epithelium singly or in the nest. So we can see along the epithelial, along the basement membrane, we can see basal cell layer, we can see the atypical melanocytes. Okay, so these larger melanoma cells, they can infiltrate the surface epithelium in a singly or in a nest. So spreading of the lesional cells along the basal cell layer, that is the radial growth pattern. So we have already read कि in the radial growth pattern, out of the 4, the 3 growth patterns we will see in the radial, only the nodular we will see in the vertical. Occurs before the invasion into the underlying connective tissue. So this superficial spreading melanoma, we will see the radial growth pattern. Now coming to the vertical growth phase. When melanoma cells are observed invading the connective tissue, we can say they have entered the vertical growth phase. That is the nodular melanoma. No radial growth of the cells can be observed in the overlying epithelium beyond the edge of the invasion tumor. Okay, basically in the vertical growth phase, what we will see? We will see the malignant melanoma, they are invading the connective tissue. So we can see invasion into the underlying connective tissue. See arrow marks, you can see they are invading the dermis. The cancerous cells, they are now can be seen in the underlying connective tissue. See here also in the photomicrograph, we can see in the underlying connective tissue, we can see malignant the atypical melanocytes. Okay, so here we can see they have entered the vertical growth phase, that is nodular melanoma. So these invasive melanoma cells, they can appear either as a spindle shaped cells or as a epithelioid cells, and they infiltrate the connective tissue as a loosely aggregated cords or sheets of the pleomorphic cells. So the cancerous cells, they can appear either as a spindle shaped cells or they can appear as an epithelioid cells, and they will infiltrate the underlying connective tissue as an aggregated cords or sheets of the pleomorphic cells. Sometimes these melanoma cells, they do not produce melanin, they do not demonstrate melanin. So these these type of lesions are known as amelanotic melanoma. Means when the melanoma cells, they do not produce melanin, these lesions are known as amelanotic melanoma. So IAC can be done. S100 protein, HMP45, Melan A, MAT1 and the Vimentin, these are the IAC markers which are used for malignant melanoma. The differential diagnoses are oral melanocytic macule, melanoacanthoma, melanocytic nevi, capillary sarcoma, and amelanotic melanoma sometimes can be misdiagnosed as squamous cell carcinoma. So according to the Clark's classification, if the cells are confined to the epithelium, they can be classified as level 1. The cells penetrating the papillary dermis, these are classified as level 2. Cells filling the papillary dermis, level 3. Cell extending into the reticular dermis, level 4. And cells invading the subcutaneous fat, that is the level 5. So this is the classification in the cutaneous melanoma which is given by the Clark's. Now coming to the treatment, surgical excision is the mainstay of treatment. 5-year survival rate is 45%. Patient with amelanotic lesions have a poor prognosis. So extremely poor prognosis we can see for oral melanomas. So this is all about malignant melanoma. If you have liked the video, please press the like button.